Hi, I'm Desiree Chappell. Welcome to Top Med Talk. It's Tuesday and it's time for my Roundtable. The Roundtable is a chance to sit down with a multidisciplinary group to have discussion about perioperative care and improving the quality of what we do every day.
Top Med Talk.
My name is Desiree Chappell, and I am joined this morning by Professor Monty Mythen of Top Med Talk. We have our special guest with us this afternoon, and I'll do a brief introduction and then ask you guys to introduce yourselves and give us a little bit about your background. We have Dr. Steve Flanagan. He is a doctor from the Physical Medicine and Rehabilitation from New York University. We have Brian Stewart. He's a physical therapist and director of the California Rehabilitation and Sports Therapy. And we have Colleen Walsh. She's a nurse. She's a past president of the Orthopaedic Nurses Association, and she is a professor at the University of Southern Indiana. So thank you guys again so much for joining us. Dr. Flanagan, why don't we start with you? Can you give a little bit about your background and how you're involved with value-based care?
Well, sure. I'm actually the chair of Physical Medicine and Rehabilitation, or what's known as RUSCA Rehab at NYU University. And part of my job is to make sure that rehabilitation is playing an important role in achieving the triple aim of medicine, which is to improve patient care, improve their outcomes, improve their satisfaction, but to do it more efficiently, which we all know is a euphemism for less money. So that we've been, I believe, successful at NYU in working with our colleagues across the institution, the health system, to do just that. And I'm looking forward to sharing what we've done and what we achieved.
Yeah, that sounds great. Brian, you are involved as a physical therapist, involved in rehabilitation. And can you give a little bit about your background and how you're involved within the process?
Sure. Dr. Kane had actually reached out to me last year, and it basically stated that physical therapists should have a role in this big scope, this interdisciplinary plan, if you will, to help address value-based care. So what I try to do is kind of spread the word about this conference over the last year, as well as try to deliver as best treatment as I can for those who make it from the hospital setting to an outpatient setting. So we see anything from joint replacements to spine care and all those sorts of things. They may come from orthopedic surgeons, from PM&R docs and that sort of thing.
So you're a frontline physical therapist?
Absolutely. We see patient. I'll see patients on Monday mornings, so absolutely.
Yeah. And Colleen, can you tell us a little bit about what you're involved with and what you do?
Well, I'm the immediate past president of the National Association of Orthopaedic Nurses, and our mission is education. And that's why I'm here. And Dr. Kane reached out to me last year, actually almost 2 years ago now, and brought me into the fold. And so what we've been doing at NAON is working to develop role descriptions for the nurse navigator, to help this process through. And we're providing education on perioperative surgical home and ERSA. And we're very committed to making sure that our patients follow that pathway and they get in and they get out. And the nurse is at the center of it because they kind of direct everything.
Colleen, that's fantastic. So today we're going to be discussing several topics, including, first of all, the role of physical medicine and rehabilitation in the value-added care bundle. So we heard Dr. Flanagan talk a little bit about that today. We want to talk about expanding the concept of that team approach of care, because I think that's what we're starting to talk about in healthcare right now. I don't know how many of us are actually practicing that. So let's talk about maybe implementation of that. And then lastly, I want to discuss the importance of pre- and post-habilitation. Right, we've heard of those terms, so maybe we can have an explanation of what that means, and the care of the surgical patient, and specifically how these concepts affect outcomes. So, Dr. Flanagan, I want to start with you. Tell us a little bit about the role of physical medicine and rehabilitation in that value-added care bundle, and how many facilities that you know of are actually pulling in your specialty into their care bundles or care pathways.
So that's a great question. So I can say that I believe that our Department of Physical Medicine and Rehabilitation is critical in the NYU system in achieving the triple aim of medicine, which I talked about, which is to improve patient outcomes, improve the health of the population, and do it for less money. And if you take a look at the role of what rehabilitation can offer, is that we're getting folks up, we're getting them mobilized. We believe that exercise is real medicine, and that's often overlooked. And there's really good evidence, and we've shown this at Rusk as well, that when you mobilize patients early on in their hospital course, even if they are in the intensive care unit on a ventilator, you are effective in decreasing their length of stay, decreasing their need for post-acute care services, saving money, improving outcomes, and you do that by involving physical medicine and rehabilitation. We were very successful in the ICU. We were very successful in the acute care floors as well. So when we were planning for the bundled care initiative for the pilots, naturally the hospital realized the value that we bring and made sure that we were involved to make sure that we were enhancing the care that they were going to get. So we increased the amount of rehab that folks were getting after their operations, and oftentimes providing their very first therapy session in the recovery room if we couldn't get them out. And after that, making sure that even when they're not on an acute inpatient floor, they're still getting therapy twice a day, because the evidence will show the more they're exercising, the quicker they get out. They're getting out healthier, less money, and they're staying out longer. So that's just a quick synopsis of what physical medicine and rehabilitation can add. I believe that we're critical in achieving that triple aim of medicine.
Mm-hmm. Dr. Flanagan, let me ask you one more question. I'm just curious. So you've been transitioning to the value-based care model, and you're a pilot program for that. Was it a difficult transition? And more specifically, it sounds like maybe this model is moving into more than just the joint program. So what's that transition like? Because we know that, that initial upfront cost of moving to that value-based care model can be a little bit more than what people expect it's going to be, and there's going to be a transition. So what have you found?
So there were a lot of transitions that we needed to deal with. In the past, there was a very heavy reliance on IRF, inpatient rehabilitation facilities, including Rusk or inpatient service, to treat those postoperative patients, whether they were in the bundle or not. And we realized that constituted a large cost of the postoperative care or the post-acute care, and that just simply wasn't going to happen anymore. So we had to go through what could have been a painful experience of shifting our services, moving our docs into more of an acute care right after the operation, providing consultations, and moving some of them over into a subacute partner to make sure that we were providing Rusk high-quality care in a subacute facility, which is very different than an IRF or an inpatient rehab facility. So there was a little bit of pain with that because there was a contraction of our number of inpatient beds. But it's also really a cultural change, and the reason why it was ultimately successful is that there was a culture in the hospital that supported that. They recognized the value that rehab offered, but they also worked with us from the very beginning to make sure that that value that we offer is shifted from a very expensive IRF model, which for some patients is still very important, but shifted that to an acute care service, to subacute, and also to make sure that we were providing services in the ambulatory side. So once those patients were discharged, we made sure that they were discharged to a Rusk Physical Therapy Center so that it kept it in the family. We were able to provide not only their high-quality rehab, but we were also able to identify problems early on, report it back to the surgeons who were in our system to make sure that we identified problems early and helped to prevent readmissions. So it was my belief that we went through the entire continuum of care, and in some instances we even provided prehabilitation, making sure that we were involved in their care beforehand, maximizing or optimizing the medical care so that we even tolerate surgery even better.
Yeah, we're going to hold on to the prehabilitation part. We're going to talk about that in just a second. Brian, as a frontline provider of physical therapy, how do you see your role as playing in this model of the team approach?
Very good points that Dr. Flanagan brought up. I think patient education, as well as just information of what the patient's going to expect. I work in an outpatient sort of role, so I may see these patients post these episodes of care, but if they've already had this prehab, possibly with me, possibly in a hospital outpatient setting, they've had surgery, maybe a day stay, and then maybe a little bit of time in home health, but by the time they come back to outpatient, those patients are usually doing that much better. So, really a big piece of that is emphasizing lower extremity strength, balance, safety precautions once they're coming back home. Are they managing stairs? All those fun safety things that patients don't always think about once they're back home, but that's a big part of that. So it might be a month before surgery, it might be 2 months. Even if I see them for a couple of visits and then I don't see them back for maybe a month after, at least they've got some things to work on early on. So hopefully they're hammering away and at least getting a little bit stronger going into surgery.
Yeah, all right. Well, again, we are here in Newport, California for the Value-Based Care Conference for orthopedic patients. Brian, you were talking about that you are in an outpatient setting, and I would imagine, and I think all of us could probably say we've had this experience, that there may be a disconnect in communication between what you're doing versus the rest of the team. So, Colleen, I'd actually would like you to comment on how we maybe manage that a little bit better.
Well, we all know that there's so much fragmentation in the healthcare system, especially with some of our joint programs. I think that the evolution of the nurse navigator role is really going to help facilitate a lot of that and connect the pieces together. I liked what they were talking about this morning, that the patient doesn't get scheduled for surgery until they're optimized. And I think that if more programs did that, I think they would do much better with their outcomes. And again, that's part of that nurse navigator role, as well as the advanced practice nurse. And, it's the other thing that was, singing music to me this morning was, working and practicing to the extent of your license. Yes. And that's near and dear to my heart. But I think that's what we have to do. Mm-hmm. And that the nurse who coordinates everything and who follows up, and I was a little bit concerned listening to all the 6,000, cases that these nurses were going to manage. And
do we have that? Do we have the nursing force to be able to?
Well, yeah, there is that. But again, my organization is so committed to providing the tools for the nurses who are, going into those roles, so that we can maximize and use the evidence to make sure that what we are doing is going to be beneficial to the patient and adding value.
Yeah. Monty, I actually wanted to bring you into this conversation because you didn't get a chance to introduce yourself and what you do. But I think that you have a perspective on coordination of care pathways and programs, a UK perspective on that.
So Monty, Mythen, we met beforehand. So I'm from University College in London, but I also was on faculty at Duke, and I've spent quite a lot of time in the last 5 years visiting almost every state in the USA. So I think I've got a reasonable idea about what's going on. So we've all become very interested in the better application of pathways, but also this improved preparation. Now, our UK experience has very much been that there's a minority of patients that we can do the occasional session with, and that they go away and they're now very adherent to these improvement opportunities, because they sort of weren't before they needed us. So it doesn't seem as though they're very likely to change now. So it seems as though they require quite a lot of supervision. And the other factor I think we're learning is that we need to do something to support them psychologically often. Is that, I don't know if you work with sports psychologists as well, but if you could touch on those 2 points. We find the sort of motivated are easier to motivate more, but the unmotivated tend to need quite a lot of supervision.
I see that from just every patient, for the most part, that I see, at least on a day-to-day basis. It could be a sports injury, it could be a work injury, it could be a weekend warrior who's now had a total joint replacement. That sort of motivation and how someone deals with pain is huge. So someone needs a swift kick in the rear end. Others need their hand held a little bit along the way. So getting into that psychology is huge.
So sorry to interrupt, Brian, but when I see our ex-athletes, including the weekend warriors, they seem pretty easy to remotivate because it's in there, But the activity avoiding individual, the lifelong committed activity avoiding individual, is quite hard to change with a pamphlet and an hour or so.
I think you're right, and I think that may take a little bit more of maybe guidance from a group of individuals versus maybe just one doc, one nurse, one PT. It may take a group of specialists to kind of have that kind of multimodal, if that's the right
multidisciplinary
multidisciplinary approach.
So I think it's again moving to that. Dr. Flanagan, what is your experience with that team approach and bringing that psychology piece in?
So I would say that rehabilitation medicine is, I think, the perfect example of a team sport in medicine, where there's a group of folks, many different professionals, physiatrists, physical therapists, occupational therapists, psychologists, social workers, you name it, vocational counselors, all working together. And it's really that team approach that I think is very important to success, because we all do different things with the same goal in mind, which is to improve the care of the patient and improve their outcomes. And I think one of the important things, particularly with folks going for surgery and preparing for what's happening next, is to really educate the patient. This is what's going to happen. You're going to have your operation, but expect that your first physical therapy session may very well be in the recovery room, so that they're not shocked when they're being told to get off the gurney and exercise. Also expect that once you're on the acute care floor that you're going to get physical therapy or occupational therapy at least twice a day, and that's going to go on for a long period of time. So it's really setting the expectations. And when you have the entire team and the entire culture of the institution, the team, promoting that, it becomes a little bit harder for the patient, the couch potato, so to speak, to say no. You won't be able to motivate everybody. We just have to accept that. But boy, we can be successful with more people if everybody buys into it, and it's the culture of the team and of the institution.
Well, and everybody becomes part of the assessment every day and has the input on that. Because, Colleen, you can speak to this. As a nurse at the bedside, you know when something's not right with your patient, exactly. and you're always trying to come up with, how am I going to get around this? How are we going to deal with this problem and motivate them in certain ways? So I think that, you start with your front line and then work your way through the rest of the team.
It's that patient engagement piece, and it was very well described this morning. We're still kind of that doctor is the God syndrome, and some patients think that, but it's having the patient. It's the buy-in. Is trying to get the patient to buy into the fact that this is your health care. You are the center of my universe, and you need to tell us what you need.
Yeah, patient-centered care, shared decision.
Exactly, and patients are not used to that.
Yeah.
They're not used to that model, and so as nurses, we have to really, and physicians, we have to really educate them that, okay, you're here, we're going to work together, but you're driving this, and what do you need, and how can we help you?
We hear a lot about prehabilitation and post-habilitation, that coining the new phrase when it comes to enhanced recovery and care pathways. And I'm interested to hear what your experience has been with the preoperative optimization part of this and prehabilitation, as well as, Colleen, you're actually speaking today about early mobilization and rehabilitation post-operatively. So would someone like to comment on the prehabilitation piece? Have you had experience with that, Dr. Flanagan?
Well, sure. One of the nice things where I work at NYU Langone is that we're able to really provide care in a setting where we're all working together. So our orthopedic center, for instance, has physical therapists, physiatrists, rheumatologists, and orthopedists. So the orthopedist plans surgery and sends them right down to physical therapy to start working on plans for improving strength even before the operation, and that has been actually very successful.
Brian, have you done any prehabilitation in your practice?
I've seen some. Being in an outpatient sort of setting, it's a little different than being direct with the hospital, but I think the communication piece is huge where, it can be a few visits to start, make sure they understand a strengthening program, as well as once they are discharged home, they may have had a few visits to home health PT, and then now they are in an outpatient setting. Then a lot of times that's where I'll see patients for the bulk of their time. So unless they knew they came to see me with knee pain early on, hey, by the way, I'm going to have knee replacement surgery in 6 weeks or something like that, they may be seen for a period of time. They may disappear for a little bit and then come back that way. So, yeah. So,
as far as post-habilitation or rehabilitation, Dr. Flanagan, you've mentioned several times about that the patient may actually start receiving their rehabilitation or post-habilitation in the recovery room. Final comments on, and Colleen, if you can speak to this, the importance of early mobilization in post-op joint care.
If the patient's out of the bed, the patient doesn't get into that sick roll. They just don't, laying with the wet washcloth on their forehead. We've all seen that.
Absolutely.
Wet washcloth syndrome is not a good thing. Sooner they're out of the bed, they're out of that sick role and into the active role. And I think that part of that psychology that we talked about earlier, that's really a key piece. It's another buy-in piece and gives the patient more control.
Yeah. Well, I can't thank you guys enough for joining us today during the roundtable discussion here at the Interdisciplinary Conference on Value-Based Care. Thank you guys so much. Signing off.
Thank you.
Thank you.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.